Without further delay, I want to introduce Dr. Cherie Simpson. She is the Senior Adult Specialty in Healthcare at Arden. I'm sorry. No, that's okay. Well, okay, that's fine. Come up and introduce yourself.
Good morning. So my name is Cherie Simpson. My slides will be up here in just 1 second, and you'll see I have a lot of letters after my name. I am a Ph.D. in nursing, so I am Dr. Cherie Simpson. At the clinic, though, it's just Cherie because I am not an MD, and I don't want to confuse our clients and patients. I do work at Senior Adult Specialty Healthcare and Research. It's a geriatric outpatient psychiatric practice and research that we conduct in Alzheimer's and mild cognitive impairment are the predominant studies we have right now. So with that said, that's who I am. What I'd like to know is a little bit about who you are today. How many of you are actively caregiving for someone with dementia? Phew, okay. How many are not caregiving but are worried about getting dementia themselves? Okay, smaller. How many are caregiving and worrying they're getting dementia right now? Yeah, okay. So what we're going to try to do today, Chris, I'm ready, Chris. So Chris is my clicker back there. Oh, yes. Does everybody have a handout? There's a handout on the table that are my slides that you are welcome to write on, make notes on. Does everybody have a handout? Great. So in our short time now, I have 4 things that I want to try to do. I want to be sure that I clarified for you what dementia is. But then what we're going to talk about are the 4 major causes of dementia. And the big question is, why does it matter what kind of dementia it is? And then we'll talk a little bit about why it doesn't really matter what kind of dementia it is. But when I say that, why does it matter? Have you asked that question yourself? Does it matter whether it's Alzheimer's? Does it matter whether it's just dementia? There's a lot of confusion sometimes about the difference between those things. So let's define dementia. You're on, Chris. Great. So, normal aging. We all have it. Our brains are shrinking at this very minute. There's nothing we can do about it. As we age, certain processes change because of that. We don't process information as fast, we don't filter information as fast, and therefore we have our senior moments. You walk into the room and what? Why was I here? What did I come in here for? You put down your keys in the same place you do every single day, but you go to look for them and you're like, where did I leave my keys? Oh yeah, they're by the door where I always leave them. The key about normal aging is it's annoying as heck. It's great conversation with all of our friends in their same peer group, but it doesn't get worse and it doesn't stop you from functioning well. But for some people, as they age, they'll develop problems, and the next level is called mild cognitive impairment. And here you still have those problems of forgetfulness, but it might affect other aspects of your thinking, and other people are starting to notice, but you're still fairly high functioning. But some things, like if you're still working and they have a new computer software program, it might be more difficult. Your boss gives you 4 different projects that you used to be able to manage, and now really you can't do that as well. You might be getting lost when you're driving to strange places. Mild cognitive impairment is, for some people, a stage of change in the brain that will stay the way for the rest of their life. Sometimes it can get a little better, and sometimes it can advance to a dementia. Dementia is on that continuum. Some like to call it a syndrome. I call it a major symptom of cognitive change. It's a symptom in the sense that it affects how we think, not just our memory, but all aspects of our thinking. But the difference between dementia and the other 2 stages I talk about in normal aging and mild cognitive impairment is the breaking point is it starts to affect your ability to function as you did before the disease process. That's the major demarcation, is a change in function, that you don't function at the level that you used to function at. And when I say that it is, oh, I'm sorry, Chris, no. Chris and I, we have to figure out our clicker system here. As I talk about changes in thinking, It is not just memory, but that's the predominant thing we'll talk about in Alzheimer's disease. But it does affect other aspects of your thinking. It can be language, and out there that phrase is aphasia in this third bullet. It can affect and cause apraxia. Praxis is when we have the range of motion, the strength, and the dexterity to do a task, but our brain can't tell us how to do it. And so if I had told all of y'all to put down your pen and wave to me, go ahead and do it. Thank you. Good morning. Good morning. Your brain understood what the concept of wave was and knew how to tell your hand to get it up there and shake it in whatever fashion you do it, right? That's praxis. And when you have apraxis, those things break down. And it might be a subtle thing like the person doesn't remember how to fasten the seatbelt. They have the strength and the range of motion to do it, but they can't figure out how to do it. And as dementia advances, they can pick up the fork and bring it to their mouth, but they can't figure it out, really. They can't get the food on the fork and get it to their mouth. So that's apraxia. The other, agnosia, to have the ability to interpret senses and understand what they are is something that we do now. An example of that is stereognosis. And that would be if I were to ask you to close your eyes and put a paper clip in your hand, you could feel that and tell me it's a paper clip. Or I could do it with a coin or a ring, and your brain knows from that sensation. When that starts to break down, that kind of example, you wouldn't be able to tell me what it is. And you'll see it in your loved ones when they're being tested and they ask them to draw those interlocking pentagrams or a cube. That's called constructional praxis. That's the ability of the brain to understand what that diagram is and tell their hand how to do it. And the last is impaired executive function. So that's our higher order thinking. That's our planning, decision making. It also has to do with our social cognition, our social filters. I always used to love the example of my father-in-law who was a Presbyterian minister, and as he progressed in his dementia, the social filters were gone, and he would be attending church, and a little boy in front of him turned around and started making faces at him in the middle of the sermon, and Doug started playing with him in the middle of the sermon out loud, and everybody was very gracious about it, but his social filter of understanding where he was and what was appropriate was eroded. So when you have problems in those areas, and it's not just one, because if you just had memory loss, what would that be? Amnesia. Pure memory loss and just memory loss is amnesia. But dementia is when you have memory loss in combination with these other factors of thinking, and you can't function it the way you did. That's dementia. But it's not the disease process. It's not the cause. But the other thing to note is in a disease process, you can have behavioral changes and personality changes, which are above and beyond just thinking changes. And these are important because these are some of the ones that are more difficult to deal with. So Chris, if you would, before I change the slide, I just want to share the faces of dementia with you in the sense that one of the best things that has happened to us is that people have become more public about their disease process. And so we have great examples in Glenn Campbell, who actually came out and started touring again, singing with the support of his family, showing you that life after the diagnosis of Alzheimer's doesn't mean that it has to be all negative. And down at the bottom, Pat Summit represents early onset dementia, and I'll talk about that just very briefly. And then the gentleman at the top, all of our family members. And the woman on the left, my mom. And I'll get tearful, happens every time. She passed in 2003, but I was a caregiver for a while. And so I always include her because that's why I'm here. Okay, whew, I'm back together. Thank you. All right, Chris, you can change it. All right, so this is a wonderful picture to remember. Dementia is this syndrome, this symptom that is a problem in your thinking, but the causes of it can be many things, many disease processes. The biggest ones we're going to talk about today are Alzheimer's, vascular, Lewy body, and frontal temporal. But there are other causes, and we'll briefly talk about what the difference in those are. On the right is a picture of remembering the umbrella, but who's affected by these disease processes the most? Of course, we know that Alzheimer is the leading cause of dementia. In this slide, it says vascular disease is the second. If you look on the Lewy Body Association's website, they'll tell you it's the second largest cause of dementia. I'll let them fight it out. It doesn't matter. It's all a horrible disease. And then the third one is frontal temporal dementia, which represents a very small portion of the disease process, but as we learn more about it, it's one of the more complex situations. Okay, Chris? So let's talk about Alzheimer's disease since it's the #1 cause. The most important thing to know about it is, I probably already have it. It's a disease process that starts very early in your lifetime, probably in your 30s and 40s, but it's a disease of aging. You don't see those symptoms until you advance in age. And so the difference between early onset and late onset is just that. Early onset is Alzheimer's dementia that starts before the age of 65. It's actually a slightly different disease process in the sense that it's much more rapid and it's much more tied genetically in a family. Late onset is Alzheimer's disease that starts after the age of 65. And for most people, it really is in their 70s and 80s when you see the symptoms. The process of the disease is a dysfunction, as we understand it today, is a dysfunction of proteins. Now, not like the steak that you eat, but your body is made up of proteins that are building blocks. And two of the major proteins that you'll hear about in Alzheimer's disease are amyloid and tau. And you might have heard of plaques and tangles. So the amyloid proteins become dysfunctional. They actually leave the cell, clump up, and kill the cell. Tau protein is a protein that is in the cell. And I should say, amyloid is something we all have, and our bodies process it normally and get rid of it, and it's no big deal. But in the Alzheimer's situation, we don't understand what causes that amyloid plaque to form yet. And the research is in all the sorts of different possible drugs to stop the plaque from turning into its clumpiness. Tau protein is at the top. Plaque representation is at the bottom. The tau protein is something that is in the nerve cell that actually is reforming all the time. And it creates like this railroad track for the nerve to send the signal down. And something happens to that railroad track in the tau protein, and it tangles up, and that kills the cell. So two different protein dysfunctions, as we understand it today, are killing the brain cells that cause the dementia process. Now then, Alzheimer's is characteristically noted by the fact that it starts usually with memory loss. Those are the first things that you see. And that it's a slow process. Most of the time, people aren't diagnosed until like 2 to 3 years after symptoms start, because they get bad enough where everybody's really starting to see that there's a problem. But usually when families learn the diagnosis, they'll go back and go, oh, this happened to me. My aunt said, oh, well, I wondered why your mom got lost driving out to the lake cabin. She'd been there many times before. I didn't know that. That happened 6 years before we got a diagnosis on my mom. And so it's a slow, insidious onset. It usually starts in people, as I said, after the age of 65. The life expectancy is on the average after the diagnosis 8 to 10 years, but that is so variable. For some people, it can be fast and be 3 years, and for other people, it can be 20 years. So that's another thing to note, is there's so much variability in this because of our own individual selves. Our health before and our health afterwards are very big determining factors about longevity. The other thing about Alzheimer's disease and the rest of the disease processes is that there's something called behavioral and psychological symptoms of dementia. These are symptoms like depression, anxiety, agitation, disrupted sleep patterns, disrupted eating patterns, inappropriate behaviors. With Alzheimer's patients, it's those gamut of symptoms can vary, and I'm sure you've all out there experiencing it. And so when I test somebody and I use a screening tool called the mini-meal status exam, it's a 30 questions. Some of you have probably seen your loved ones do that. I could have someone who scores 17, and they can sit there and talk to you as if nothing is wrong. And if you didn't know they had the disease process, you would not suspect that there's an issue with them. But knowing them knows that although she's sitting there telling me that she drives to the gym every day, she shops at H-E-B, she buys a chicken, she uses it on Monday to make sandwiches and yada, yada, all this. At her home, one, she doesn't drive anymore, she doesn't go to the gym, her house is in disarray, and she has nothing in the refrigerator because she hasn't been shopping. Her friends figured all this out and brought her into our clinic. And so again, language skills very good. Short-term memory and her ability for judgment, gone. Another person with 17 as a score can have a very difficult time with communicating. They have a very hard time with word finding. They may have some difficulty with agitation and anxiety, and be a very different picture. So that's to say that Alzheimer's disease, even though we can talk about some general characteristics that are the same, it's very individual depending on where it's occurring in the brain, what part of the brain is attacked more. The other thing to say about Alzheimer's before we go into vascular is about risk factors. There really aren't a lot of known risk factors for Alzheimer's disease other than aging. And yes, everybody always asks, what about, is it genetic? Am I going to get it because my mother had it? And that is, there are some genetic predispositions. You've heard probably of the APO4 gene. So people who have the double APO4 gene are at a higher risk, 30 to 40% higher risk than those who don't at getting the disease. But it's only a risk, it's not a determinant factor, okay? It's only a risk. So many other things play into it. Again, we know education. Higher education somehow seems to be a protective mechanism. We know exercise, and exercise is a protective mechanism. So there's a lot of things that make it a predictor, but not a determining factor. Different than in vascular disease, there are some very significant risk factors for developing vascular disease that we'll talk about. But what is that? Well, vascular disease is a loss of circulation to the brain cells that causes them to die. Now, brain cells are killed off by either a blood vessel bleeding or a blood vessel being occluded. Most of us have heard of strokes, and that's represented at the bottom on the left, that big infarct. When a person has a stroke, enough of the brain is killed that they have permanent damage. Usually you think about it in motor, but they'll have changes in their cognition as well. But what is more in what we're talking about today is that smaller microvascular disease. And this is where small bleeds happen to the very smallest. That's good circulation. No occlusion there. Small vessels are damaged that cause brain cells to die. And therefore, it can look like Alzheimer's in the sense that it can be slow, it can be subtle, but it also can be very quick. It can be, mom was great before she went in and had her coronary artery bypass graft surgery. Or after mom's heart attack, things seem to get worse with her memory. So the cause of it is different. It can sometimes look a little bit like Alzheimer's, but what's different is the course of the disease. Where with Alzheimer's, it's a slow progression over time. With a vascular disease, it's often a stair step. They'll lose some function, they'll stay there until another vascular insult happens, and then they'll drop function, so it's a stair step down. Now, Lewy body is up here with Parkinson's disease because they're very much related. Parkinson's disease is also this protein dysfunction. The difference in the two is where it starts in the body, in the brain, and how it shows up. So there's actually 3 scenarios here. A person can have this protein dysfunction in an area of the brain called the substantia nigra, and they'll have motor problem movement disorder first, and they'll be diagnosed with Parkinson's disease. They can have these Lewy bodies happen in other aspects of the brain, and they will have onset of usually slow memory loss that looks a little bit like Alzheimer's, and sometimes is first diagnosed as Alzheimer's until other symptoms develop. Or they can present with Lewy body and have severe changes in their perceptions and have hallucinations and delusions being the predominant thing that shows up first. And in the situation of Lewy body first, they'll have the memory issues or the hallucinations, and they may develop motor problems down the line. Likewise, Parkinson's disease patients may develop dementia down the line. So they overlap to a certain degree with the same core reason for the reason they start. The gentleman said, it seems like it's not fair. My mom told me life's not fair, but this is where it's really, really not fair. Really, really not fair. So the symptoms with Lewy bodies that I said, thinking and memory can show up first, but the other part of it that's different than Alzheimer's disease is that they also have difficulty with body regulation. So not emotions like we talked about with vascular, but that can be part of it, but more that they'll have body temperature regulations. They'll be really cold all the time. And they also have trouble sometimes with their blood pressure will be difficult for their brain to control. So they have a little bit different symptoms than Alzheimer's in that regard. And the other one that's key to Lewy body that as the disease progresses, sorts it out from Alzheimer's, is that Lewy body fluctuates. When we talk about an Alzheimer's patients, and all of you who are caring for somebody with Alzheimer's know they have good days and bad days, right? You know there's going to be some days you wake up and you're not even going to try to go whatever, get a shower that day, go to the grocery store with them. And then there's other days that everything runs smooth. And that really can be determined by how much sleep they got that night, how much stimulation they had the day before. But if I did an MMSE on them, it'd probably be a 17 on a good day and 17 on a bad day. Lewy body, we're talking about some days they look like they have dementia, and some days you don't think they have any dementia. That kind of fluctuation of attention, particularly. So it's a little bit different in that regard. The other thing about it is that it starts earlier than Alzheimer's. And again, I'm talking about late onset Alzheimer's, not early onset, the different disease process really. But in comparison to Alzheimer's late onset, this can start as early as 50. It does have a shorter lifespan in general, 5 to 7, but again, variability is high. It can be as much as 2 to 20 years. And not as many risk factors like with vascular that are clean that you can talk about. Being over the age of 60, so again, the longer we live, the more opportunity there is to see the disease process show up its symptoms. And actually talking about unfair, here males have a higher risk of this disease than women do. And if you have a family member who's had Lewy body disease or Parkinson's disease, your risk factor is higher than those who don't. All right, next slide. This one is the complex one in the sense that we don't talk about it so much as a frontal temporal disease as it's usually labeled frontal temporal dementia. And that's because it's really a cluster of different processes, different diseases. But it does go back to protein dysfunction again. And in this situation, the tau protein that I talked about in Alzheimer's is at work here in being dysfunctional, as well as, don't worry, there's no test on this, but a protein called DTP3 also is dysfunctional and causes the cells to die and the brain to shrink. The difference about this is that, again, here, this is occurring, the symptoms are showing up much earlier in the age ranges of 40 to 45. So while there's not as many frontal temporal dementia patients as there are Alzheimer's patients when we talk about late onset, there's about the same number of frontal temporal dementia patients as early onset dementia. So it comes on early, and people have really 3 different kind of presentations for frontal temporal dementia. The first one, as you see there, are dramatic changes in personality. So in Lewy body, the scary thing that happens is hallucinations and delusions. And I guess I should clarify, hallucinations are seeing things that aren't there. Delusions are thinking things that aren't real. The ones that hurt the most are when they think that their spouse is having an affair, when they think that they're cheating on them. Those are hard to deal with. And so these are the 2 major kinds of frontal temporal dementia. But if you go to the next slide, I mentioned that there's some other causes, and this goes back to the slide with the umbrella and the different causes underneath of it. The first 2 up there, progressive supranuclear palsy, is the 3rd subgroup of frontal temporal dementia. So the first group was the behavior changes. The second group was the language changes. The third group is the movement change first. And in this one, progressive supranuclear palsy is a situation in which you get muscle stiffness, you get a change in your walking, and change in the posture. The corticobasal degeneration is just where the arms and legs lose motor control. Now, the one that I didn't put up there, because it gets really confusing, is ALS, amyotrophic lateral sclerosis, is also in this group. So frontal temporal is this really weird place of crossing between what we think of when we think of dementia and these other disease processes. But there are other causes of dementia that we have to think about and try to sort out. Viruses can cause dementia. So oddly enough, things like syphilis, HIV, Lyme's disease can settle in the brain and create nerve cell death that can cause dementia. Alcohol is actually a growing problem for causing dementia in the older adult. What happens here is that alcohol abuse leads to a B vitamin deficiency that then kills the brain cells. Someone mentioned to me while we were talking out front about the fact that their loved one with dementia played football. And so everybody knows what's happening there in the news with the concussion history that football players and other people who do contact sports or soccer players with long history of headers, that continual trauma of encephalopathy to the brain can then lead to a dementia. So there are other causes for dementia other than the big four that we talk about, but luckily where there is something else we need to know about is there are some medical conditions that can look like dementia, but when they're fixed, you get fixed, which is a good thing. Some of those examples are people who are experiencing severe depression will have very difficult time concentrating, focusing, learning new material. So if they were to take an MMSE, they might score a 17. If you correct and help the depression, their cognitive abilities improve. If someone has severe sleep deprivation, you can't concentrate and think, and you can score in the area of a dementia. And others are things like thyroid imbalance. If your thyroid, and I don't mean just a little tweak, you know, like all of us women always wish our thyroid's out of balance, because if you could just fix my thyroid, I'd drop those extra 20 pounds. We're not talking about that kind of imbalance. We're talking severe imbalances. They can cause you to not be able to think and concentrate and look like you have a dementia. So those are all the different causes of dementia. I'm going to stop right there and just see if there's any burning question before we go on to why does it matter. Any burning questions about it? Okay, there are. Thank you. That helps me. I'm going to keep going because that tells me how much time I need to wrap up so you have time for questions. All right. The big thing is, why does it matter? Why does it matter to you? Does anybody want to answer that? Treatment. What else? Early diagnosis and preventative measures. We can talk about that. Early diagnosis and preventative measure. So treatment options. What else? Understanding what's going on. Anybody else? Well, for me, I'm a control freak. I like to know. The more I know, the better I do. I'll tell you, if I have a little ache or pain, it worries me until I go to the doctor and he goes, oh, you have a mild tendon strain. Okay, fine. It doesn't hurt anymore. Now I understand what's going on. And so for me, as a control freak, the emotional and cognitive factors of understanding this diagnosis are huge. I see it every day where family members struggle with trying to sort out what's the disease process and what's just my mom being stubborn. I see it every day where family members get into situations where they're reacting to situations because they don't understand what's going on. or they've tried their hardest to manage it on their own, not knowing where to turn because they don't have enough information. Now, tell me that doesn't wear on you as the caregiver. And how do you make decisions about what's the right thing to do for your loved one if you don't understand what's going on? I think the other important factor here is somebody's mentioned it, is too, what's the impact to my family? Not only in the helping other people, oftentimes I'm dealing with a spouse, and they'll say, you know, my son just can't handle this. He just doesn't understand. And he treats his dad like his dad's making mistakes. I don't know how to help him. So it's not just the care recipient and the caregiver, it's the family unit. But then there's also the issues of what's that mean to my family unit in the future? Who's at risk for getting these diseases? And so understanding as much as you can help not only with current dealing with it, but future planning as well.
My mom took
Donepezil?
Donepezil, and she also has 14 times the normal thyroid. And so she was taking thyroid medication, and the doctor wasn't monitoring it. I don't know, we'd send her in for, tests every 3 months, and apparently he doesn't read them. And so 14 times what was right. So now we have to do it the opposite way, and so she's on a different drug to reduce it. But my question really is she had huge hallucinations and a lot of delusional behavior, and I think you kind of answered it let's say that she didn't have Lewy bodies. Do other types of dementia have that same?
Right. Those behavioral and psychological symptoms of dementia, which include psychosis, hallucination, and delusions, can happen with Alzheimer's patients. It's not unique to Lewy body. So Alzheimer's patients can develop hallucination and delusions. It's just usually not the first thing coming through the door at you like it can be in Lewy body dementia, but it can happen. And I had another thought about that, but that's okay. Yes, it can happen in Alzheimer's disease, to answer your question. Okay. Another question? Yes, sir. Sir, my timer back there. I have 5 minutes to...
What usually ends up taking the life? Is it just
That's a great question.
stopping breathing or what?
That's a great question. Because Alzheimer's dementia is now a terminal disease. And so if nothing else happened, yes, the body just slowly, I just call it forgets. It forgets how to eat. And so one of the main hallmarks you see towards the end of the disease is that the patient will start losing weight, even though they may still be eating at the same rate that they were before. And what usually happens, though, is more of something else comes along to make it happen. So another thing that happens is that Alzheimer's or dementia patients have difficulty remembering how to swallow and to get the food down. So that can lead to aspiration pneumonia, where the food goes down into the lungs and creates pneumonia. And so a secondary infection can cause it. Other times it can be other things. So again, the life expectancy after that, we'll just use Alzheimer's disease, may have to do with what before Alzheimer's your health status was. So if you had uncontrolled diabetes, if you had other heart problems, if you have COPD, those other disease processes might be the cause of death, but you have to think that the underlying dementia made them more fragile. So the two together made for a shorter lifespan. Yes?
We talked a lot about Alzheimer, varieties of Alzheimer disease. Now, vascular disease, my patient got vascular Alzheimer after he had 4 heart surgeries. Now, there are some risk factors for this, like diabetes and blood pressure and etc. If you control these risk factors, do you think the dementia that the person has, and the person is also old, it would rescind and he would be normalized and he will have just plain old age memory loss or something like that? And second question is, if after the medication, the patches were given, the person's ability to understand was very bad. In fact, he started going to the bathroom to get drinking water or something like that. And then I had to stop those patches.
Patches, okay.
Does that mean that he has, other than vascular disease, even though it started after these 4 surgeries, he has Lewy body or something like that, but he doesn't have any delusions though.
Okay. The answer to the second question is no. It doesn't mean that he has another form of dementia. Not everybody responds well to those 4 drugs that we have to treat with. Some people, it makes them worse. Some people, I just had a patient come off of Aricept, and her family says she's much clearer off of donepezil than she was on it. So just because those are the only drugs we have doesn't mean they work well. And oftentimes when they're working well, it means that you don't really notice anything different, that the person just stays the same, which is the blessed thing we want. If they scored a 17 a day and a year later they score a 17, then the medicine did its job. If they didn't take the medicine, they might have gone from a 17 to a 15 on that test. So that's all that medicine's going to do, is slow it down. So to your first question, now I've lost it. The risk factors, yes, great question in the sense that if you have purely vascular dementia and you treat everything that's the risk factor and you slow down the disease process in the sense that you prevent further vascular events, they will stay at that spot for longer. You probably won't be able to prevent all of them, but you will enhance their ability to stay where they are. People who have strokes are down here and they recover some and they get better, but they usually don't go all the way back. Okay, so they probably won't ever go all the way back. They could get a little better. But the important statement from that is that what you do to take care of yourself, everything you think about for your heart is good for your brain. So exercise, sleep, diet, all of that is good for your brain. So nothing wrong with doing all of that for your brain.